Hello, everyone. Hope you're all having a good day so far. Welcome to episode 16. Today is Wednesday, December 23rd, 2020. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Now, as of the recording of this episode, the coronavirus death count is just over 308,000 lives lost in the United States. But we have vaccines from Pfizer that have rolled out already, and Moderna is soon to follow. So let's stay hopeful that we can turn this pandemic around. Now, did you need compliance tips for the home health setting? Well, I get into it in this episode. This episode highlights a recent OIG compliance audit and my trusty tips on home health agency compliance. And I also share some fitting words from Charles Darwin. If you've checked me out on LinkedIn, you know I'm all about compliance and protecting our physicians and valued healthcare professionals when it comes to the business of medicine. I hope this week with me brings you enough to take back to your organization, to want to dive in deeper, to use my tips and best practices to ensure success. I hope this podcast will help you boost the quality of documentation capture and improve coding accuracy as you help your providers paint the medical picture. If you like what you're hearing, please go ahead and hit that subscribe button now so you don't miss an episode. Please write in a review and rating on Apple Podcast, wherever you listen to my podcast. I'd really love your support. Now, a quick disclaimer. Before I get started on the episode, this podcast episode and Nexsen Pruet podcast series do not constitute legal advice, but I am fortunate to work with sound healthcare attorneys at Nexsen Pruet. And as their consultant, I have over 10 years of experience in front office, back end, coding, and billing for multi-specialty physicians, compliance, and auditing for both E&M and surgical operative reports. Again, the opinions and insights throughout are mine alone, and they in no means constitute legal advice. So, let's get into Newsworthy. Now let's talk about why the OIG conducted this very important home health agency compliance audit. Now, under the Home Health Prospective Payment System, the PPS, the Centers for Medicare and Medicaid Services, the CMS, pays home health agencies, HHAs, a standardized payment for each 60-day episode of care that a patient receives. The PPS payment covers the intermittent skilled nursing and home health aid visits, as well as a variety of therapies like physical, occupational, and speech-language pathology. They also cover medical social services and medical supplies. Now, the OIG's prior audits of home health services identified significant overpayments to HHAs. These overpayments were largely the result of HHAs improperly billing for services to beneficiaries who were not confined to the home, otherwise known as homebound patients, or were not in need of skilled services. Now, the OIG's objective was to determine whether this particular agency complied with Medicare requirements for billing home health services on selected types of claims. Now, how did the OIG conduct this audit? Well, they conducted it per their usual standard. They selected a stratified random sample of 100 home health claims and submitted these 100 claims to an independent medical reviewer. Now, what did the OIG find in their findings? They found that the agency did not comply with Medicare billing requirements for 32 of the 100 home health claims that they reviewed. That's a 32% error rate. Remember, OIG places rates of accuracy at 95%, so this error rate is simply too high. For these claims, the agency received therefore overpayments of $75,461 to be exact for services provided during the audit period of October 1st, 2014 through September 30th of 2016. Now, specifically, the OIG details that the agency incorrectly billed Medicare for services provided to patients who were not homebound, nor did they require skilled services. And of course, on the basis of these sample results, the OIG then and therefore estimated that the agency had received a global overpayment of at least $1.7 million for the audit period. Now, all 100 claims within this sample are outside of the Medicare 4-year claim reopening period. So what did the OIG recommend, and what were the HHA agency's follow-up comments on the audit report? Well, the OIG recommends that the HHA exercise reasonable diligence to identify, report, and return overpayments in accordance with the 60-day rule, and identify any returned overpayments as having been made in accordance with their recommendations. The OIG also recommends that the agency strengthen its procedures to ensure that, number one, the homebound statuses of Medicare patients are verified and continually monitored, and the specific factors qualifying patients as homebound are actually documented for compliance. And number two, patients are receiving only reasonable and necessary skilled services. Now, in the written comments on the draft report from the OIG, the HHA disagreed with all of OIG's findings and recommendations and stated that it does intend to contest all of the findings through the appeals process. Wow. So now I always believe these types of OIG audit reports are most helpful. So I recommend taking a deeper look into these reports and see how they may affect you, your provider, your facility. Start self-auditing your home health service claims and coordinating documentation for compliance. And now it's time for my best practice tips in Trusty Tip. So let's go ahead and break down compliance in the home health setting. Let's go over some background facts and figures and why compliance is so important. The Medicare fee-for-service, the FFS, improper payment rate for home health claims for the 2018 reporting period was 17.6%, which accounted for a 9.8% overall Medicare fee-for-service improper payment rate in 2018. The projected improper payment amount for the home health services during the 2018 report period was $3.2 billion. Now, let's go over some of the reasons for claim denials. There was insufficient documentation, which accounted for a large proportion of improper payments for home health services. The primary reason for these errors was that the documentation to support the certification of home health eligibility requirements was missing or insufficient. Medicare coverage of home health services requires that physician certification of the beneficiary's eligibility is there and documented for compliance to serve as the home health benefit. Now, to prevent claims denials. In regards to the inadequate physician certification or recertification periods, physicians or Medicare allowed Npps must certify that, number one, the beneficiary is confined to the home. Number two, the beneficiary is under the care of a physician and receiving services under a plan of care established and periodically reviewed by a physician. And number three, the beneficiary is in need of home health services. And the fourth is that the beneficiary has had a face-to-face encounter with the physician or an allowed Npp related to the primary reason for the beneficiary requiring home health services. Now, those requirements for the home health services have to have occurred no more than 90 days prior to the home health start of care date or within 30 days of the start of the home health care. And also, it has to have been related to the primary reason the beneficiary requires home health services. Now, in regards to the beneficiary is confined to the home, An individual is considered confined to the home or homebound if the following two criteria are met. Now, for the first criteria, the patient must either be, it has to be because of an illness or an injury. They need the aid of a supportive device, such as crutches, canes, wheelchairs, walkers, the use of special transportation, or the assistance of another person to leave their place of residence. Or the patient must have a condition such that leaving his or her home is medically contraindicated. So if the beneficiary meets one of the criteria for condition 1, then the beneficiary must also meet 2 additional requirements defined in criteria number 2. Now, criteria number 2 involves, to clarify, in determining whether the patient meets criteria 2 of the homebound definition, the clinician needs to take into account the illness or injury for which the patient met criteria number 1 and consider the illness or the injury in the context of the patient's overall condition. So the clinician is not required to include standardized phrases reflecting the patient's condition. For example, repeating the words like taxing effort to leave the home in the patient's chart, nor are such phrases sufficient by themselves to demonstrate that criteria number 2 has been met. So, for example, longitudinal clinical information about the patient's health status is typically needed to sufficiently demonstrate a normal inability to leave the home and that leaving home requires a considerable and taxing effort. Such clinical information about the patient's overall health status may include, but is not limited to, such factors as the patient's diagnosis, duration of the patient's condition, clinical course, if it's worsening or if it's improving, their prognosis, the nature and extent of functional limitations, and other therapeutic interventions and results. Now, regarding the part where the beneficiary is under the care of a physician and is receiving services under a plan of care established and periodically reviewed by a physician, the certifying physician's medical record and or the acute post-acute care facility's medical records, meaning if the patient was directly admitted to the home health, for the patient must contain information that justifies the referral for Medicare home health services. Now, this will include documentation that substantiates the patient's need for the skilled services and homebound status. Now, for home health agency services to be covered, the individualized plan of care must specify the services necessary to meet the patient's specific needs identified in the comprehensive assessment. In addition, the plan of care must include the identification of the responsible disciplines and the frequency and duration of all visits, as well as those listed in 42 CFR 484.60A that establish the need for such services. All care provided must be in accordance with the plan of care. Now, if the plan of care includes a course of treatment for therapy services, number 1, the course of therapy treatment must be established by the physician after any needed consultation with the qualified therapist. Number 2, the plan must include measurable therapy treatment goals which pertain directly to the beneficiary's illness or injury and the beneficiary's resultant impairments. Number 3, the plan must include the expected duration of therapy services. And lastly, the plan must describe a course of treatment which is consistent with the qualified therapist's assessment of the patient's function. And now, the plan of care must be reviewed and signed by the physician who established the plan of care in consultation with the HHA professional personnel at least every 60 days. Each review of a patient's plan of care must contain the signature of the physician and the date of review. Now, regarding the beneficiary is in need of home health services, the patient must need one of the following items. Number 1, they must require skilled nursing care that is reasonable and necessary, needed on an intermittent basis, and not solely needed for the blood draws for the purposes of obtaining a blood sample, and for number 2, for the physical therapy, and for number 3, for the speech language pathology services, or number 4, have a continuing need for occupational therapy. Now, regarding the fact that the patient has had a face-to-face encounter with a physician or an allowed NPP related to the primary reason for the beneficiary requiring home health services, the provider must document that a face-to-face encounter with the patient was performed no more than 90 days prior to the home health start of care date or within 30 days of the start of home health care. The certifying physician or allowed NPP must also document the date of the encounter. The certifying physician's medical record for the patient must contain the actual clinical note for the face-to-face encounter visit that demonstrates the encounter, that the encounter occurred within the required time frame, and that the encounter was related to the primary reason for the patient requiring home health services. And it also has to say that it was performed by an allowed provider type. Now, NPPs who are allowed to perform the encounter are, number 1, they can be a nurse practitioner or a clinical nurse specialist working in accordance with state law and in collaboration with the certifying physician, or in collaboration with an acute or post-acute care physician with privileges who cared for the beneficiary in the acute or post-acute care facility from which the patient was directly admitted to home health. Or the NPP can be a certified nurse midwife, as authorized by state law, under the supervision of the certifying physician, or under the supervision of an acute or post-acute care physician, again with privileges, who cared for the patient in the acute or post-acute care facility from which the patient was directly admitted to home health. Or third, the NPP can also be a physician assistant, again under the supervision of the certifying physician or under the supervision of an acute or post-acute care physician with privileges who cared for the patient in the acute or post-acute care facility from which the patient was directly admitted to home health. So, look at all of those details and requirements for compliance. It's critical to understand the many, many, many nuances that are required to be compliant in home health documentation capture and documentation retention if you are ever involved in a post-payment audit. So remember, by painting a true and honest medical picture each and every time that supports the medical necessity of the services you perform, your certified medical coder can then abstract codes with accuracy. And finally, this week's inspiring quote in Spark is from Charles Darwin. "It is not the strongest or the most intelligent who will survive, but those who can best manage change." Indeed, that's all of us right now. Are we surviving? Are we doing it? Are we managing the change? I think we are, here in this space of healthcare. Look at how far we've come since coronavirus met our shores. I am happy Charles Darwin's spark still shines on in all of us today. So, that wraps up today's episode. It's only 2 days before Christmas, and I know I'm ready to stay in and be cozy with Coco and lots of classic black and white movies. Wishing you all a very, very Merry Christmas. I appreciate you diving into today with me, and if you would like to inquire about my consultant services, you can always reach me through my email address at nexsenpruet.com. I'll leave links to everything in the show notes below. Please continue staying safe and healthy. Practice safety for one and all during our collective life in the time of coronavirus. Thank you for listening in on today's episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday. If you want more information from me, go ahead and follow me on LinkedIn or send me an email at sonalpatel@nexsenpruet.com for all my consulting services in medical coding, auditing, and compliance. Thank you.